So Dr. Shafer is here tonight to speak with us about the medication landscape. And what does that mean? Well, it simply means to talk about all the current MS medications that are out there right now, because I'll bet that there is somebody, at least one person in this room, that doesn't know about at least one of the medications that was FDA approved to be used for people with multiple sclerosis. So that's what Dr. Shafer is going to speak about. And then after he talks about all this, if you have any questions for him about anything to do with your MS, medication, symptoms, family matters, anything, you could ask him. We're open to this tonight. Okay? Thank you.
Thanks, Stuart.
Have a good one.
Thank you. Well, thank you. I know I'm thoroughly exhausted. All right.
Okay, check. Is that good? Good. All right. Hi, everybody. Hi. Y'all know me now. I'm Dr. Shafer. I've been up here doing yoga for the past 45 minutes. And she said no sweating. Well, I'm sweating, so my tie is down and my sleeves are up, my jacket's off, so I hope you don't mind. Stuart, thank you for having me here tonight, and thank you for our sponsors for having us here. And I see a lot of familiar faces. Some people I've seen a few times, some people just not so many, some lots, but it's good to see everybody here tonight. As Stuart said, we're going to talk a little bit about understanding the medication landscape. 25 years ago, basically when I was kind of just coming up in this area, we didn't have any therapies, and we have one. It was beta-seron. And back in the day when I was in that arena, I had a professor that told me when the beta-seron came out, he said, whatever you do, don't use that medication until the patient's really, really going bad. And then you can start giving them beta-seron. So look what's changed in the last 25 years. We know now that early therapy is very important because you want to avoid disability, right? If I tell people you have MS, if you knew you'd never be disabled by it, it wouldn't bother you. The number one thing that bothers people, any of us, would be the fact that it can be disabling. So we know now that early treatment is very important. We also know that staying on therapy is very important. And now we have, 13, 14, 15 therapies out there for MS since beta-seron came out 23, 24 years ago. So it's been a great ride for medications. It's been wonderful for MS patients. Nowadays, I've seen the change. Back in the day, patients commonly just were told, you have 10 years, do what you can do because you're not going to be getting around much. Nowadays, it's the exact opposite. 20, 30, 10, 15 years out, if you're caught early, put on therapy, it's now a chronic disorder. MS patients now today have no shorter lifespan than a person without MS in this country. So it's been a great ride. Okay, so with that, I kind of did my introduction already. I'm going to do a little MS overview. Diagnosis, treatment, monitoring, adherence, quality of life, and questions. It's all going to be centered around therapies and medication, okay? And that's I'm focusing on this. I'm not here to try to give you a lecture on MS per se. So the MS landscape then and now, I mentioned this already. I said, where were we 25 years ago? Where are we today? We had whole wards of patients years ago that having MS relapses in the hospital. You were in there for a week, 10 days, getting steroids, high dose, for 10 days in a row. It was quite a difference back then. Nowadays, it's rarely seen. Ever seen patients in the hospital. So I've already sort of gone through that with you. So demographics, it's similar. It changes sometimes. 400,000 people, maybe 450 in the country that have multiple sclerosis in the United States. We know that's an immune disorder. And I'm not going to go into too much tonight. We know that your immune system has decided that your nervous system is foreign. Your myelin, your axons, and those parts of your brain are foreign, and therefore it sets up a response called an inflammatory response to cause dysfunction to the nervous system. When that happens, the wires get affected, the communication between brain and muscles become impaired, whether it's your bladder, whether it's your muscles, whether it's your arms, whether it's your legs, whether it's your speech, whatever it may be, it's affected. Types of MS, we know there's RRMS. 80-90% of patients diagnosed with multiple sclerosis have RRMS at diagnosis, relapsing remitting MS. Patients may go on to develop secondary progressive multiple sclerosis, and there are some primary progressive patients, which is about 10% of patients, okay? So RRMS is important to understand because that's a very inflammatory disorder early on. We know that MS becomes very inflammatory, very active early on in its process, and over time, it becomes less inflammatory and more degenerative. So that's where this whole concept of getting medicines on board early is key. The new therapies I'll talk a little bit about, the orals and some of the IV therapies are highly anti-inflammatory medicines. And by minimizing that inflammatory response, we're reducing lesion load, black holes we'll talk about, and relapses. And cause, again, we don't know what causes multiple sclerosis. We know there's many factors. It may be environmental. It may be genetic. It may be exposure related. We don't know where it comes from, but there's probably a genetic predisposition. It probably relates to some degree to environment, and then also relates to some degree to whatever kind of exposures you've been involved with. Put all those things, line them up in the, I wouldn't say the right way, but in the wrong way, a person may develop MS. Signs and symptoms, again, nothing to go into heavily here tonight, but everyone here knows what the signs and symptoms are. They're all over the map because your nervous system is what dictates everything about what you feel and do. So anything goes. It may just be cognitive clouding. It could just be bladder. It could just be numbness. It could be profound weakness. It may be loss of vision in the eye. It may be ataxia or unsteadiness. It may be tremor. You name it, it happens. And so with MS, anything goes as far as symptoms and signs. Diagnosis, I put top there MS specialist. I believe as an MS specialist that you as an MS patient, so at least at some point in time in your course of battling with this disorder, engage with an MS specialist. Sometimes we see patients as a secondary consult basis. We make opinions, we make recommendations, and they'll go back to the neurologist, and the neurologist knows that our opinions are held for being specialists, and they'll carry out the good duty of taking care of the patient. And we commonly see them once or twice a year. Many of our patients we see on a regular basis, but I believe MS patients as a whole should see an MS specialist at some point in time. History and physical to this day remains the most important thing with the diagnosis, getting a good history. MS has a natural history, okay? And we know what things come involved with that. As far as physical, we use MRI now very commonly. It's a very common part of our diagnosis. And other testing, we use lumbar puncture. We use, look at spinal fluid. We look at evoked potentials. We do several things. We put all this stuff together, and we plug it into the revised McDonald criteria, and it's very specific, and we make a diagnosis. It's a complex diagnosis to make, but in the right hands, an easy diagnosis to make, and it can be done if you know what you're doing. Treatment. I mentioned earlier already, early treatment is very, very important, and I think anyone, when we make a diagnosis, the first thing we have to decide and get through is handling that diagnosis, right? Saying to the person, to you, that you have multiple sclerosis. That is a big hit first day. So we don't go off into treatment and talk about medications and all these things from the get-go, because you're not listening to that stuff the first time out. Let's get a diagnosis here. Let's talk about MS, and let's digest that piece of it. And let's go home, write down our questions, come back, and let's talk more about what MS is. And so we understand the process a little more. We kind of need to engage that first part of that diagnosis before you get treatment. Because what happens a lot of times, if you don't do that first, and that's why tonight is about medications, because if you don't have that buy-in, so to speak, with your physician and yourself about diagnosis, you're not going to stick to your therapy. You're not going to take your medicine on a regular basis. You're not going to believe in it. So we got to get through all that first. So say you have MS, look at all this literature, go home, pick out a drug, come home, come back. We're going to fail there pretty soon, sooner or later. So getting to know, and especially your physician, whoever you work with on this, getting that diagnosis down first is very important, and buying into the fact that early treatment is key. So early treatment is the first piece of that. Lifestyle takes a huge role, and I get more now into like what medicine might we choose. Are we going to use an injectable medication? Are we going to use an oral medication? Are we going to use an IV therapy that's given once a month, once a year, once every 6 months? It depends a lot on your lifestyle. Are you 24 years old? You just got married? You're going to start a family? Are we an executive traveling around the country? Are we an accountant? Are we outside working a lot? All these things play a role when we try to understand what therapy. And we're lucky. We have all these medicines now we can do this with. Before we had one medicine, maybe two. Generally, we're all injectables. So we have multiple things to think about with lifestyle. So lifestyle matters very much so in the drug we choose. Choices of therapy. There's lots of therapies out there. We have the base DMTs that you all heard about. Beta-seron, okay, interferon, which is basically Rebif, and Avonex, Copaxone, glutaminyl acetate. These drugs are very, very, very powerful medicines. They're very effective medications, and to this day, some of the top prescribed medications in the country. There still are. They're very important. They're called base therapies. And what we have with those medications at this point is we have history. We have 10, 15, sometimes 20-year data now with these medications on safety and efficacy and long-term safety and efficacy. So some patients, when I talk to you, they say, listen, I know these new drugs are great, but they've been out 3 or 4 years, maybe a year or two, but, you know, for me, my risk tolerance, which is what you think about when you talk to patients, is I want a drug that I know is safe, it's been on a long time, and it's effective. So we still are prescribing these medications on a regular basis. So those are injectables. The Copaxone now is thrice weekly, 3 times a week. I have some patients that refuse to go to 3 days a week. I want 7 days a week because I know I'm getting my medicine every day. And that's fine. You know, if it works for you, it's great. We'll talk later about when we kind of decide to make moves on treatment. Avonex is now once a week. Plegridy is sort of a newer formulation of interferon that's given every 2 weeks, twice a month. And then we have Rebif, again, 3 times a week, and Beta-seron is still out there. We moved into the newer therapies. We moved into Tysabri, which is natalizumab, which is one of the first generation monoclonal antibodies. A monoclonal antibody means mono means one, clonal means the same antibody. So it's just it's a medication that targets a very specific cell receptor and it prevents these cells from migrating into the nervous system. Okay, very effective. And Tysabri came out with a bang when it first was approved. It was used sometimes with dual therapies with Avonex and such. And we quickly had a couple of cases of PML. Everybody remembers the PML issue. They pulled the drug from the market voluntarily. And within 6 months, they go see me 3 to 6 months. The FDA said, no, get it back on the market. Safe drug. We know what's going on. Get it back out there. Good thing they did. It's one of the best therapies that we've seen out there to this day as far as treatment goes. Lots of patients who've benefited by it. But again, it's not for everybody. And I'm not going to get into the nuances of it, but we have ways of testing the JC virus. We have ways of stratifying people on their risk of developing PML with Tysabri. And we still use it very commonly in patients on a regular basis. Yeah, I sure can. Okay, stay back in the light. How's that? My makeup okay? It's good. Okay, stay in the light. Okay, I'm too far from them though, so I beat up with them. Okay, so Tysabri. Then we start moving into the new oral therapies, okay? Fingolimod was Gilenya, came out of the market next. Tecfidera has come out to the market. So we have those drugs. Aubagio has come out to the market. These are oral therapies that are very effective in treatment of multiple sclerosis. They reduce relapses. They reduce lesions in the brain. They reduce disability progression. In their own population sets, when they study these drugs, all very effective. And in some ways, some of the data, some of the newer therapies have shown a little bit higher numbers in regards to reducing inflammation in the MRI, in reducing relapses and reducing disease progression, but really active in the MRI arena as far as the new oral therapies. So those are very effective. And who are those patients we use them with? It depends. If you're on a therapy, we look at several different things when we're trying to assess how we're going to monitor medications. That it plays a role in what we choose to use with you. Okay? Because we'll talk to you, we'll say, hey, you're going to go on this medication, Gilenya. We have to do an echo. We've got to do first dose observation. We need to do EKGs. We need to look at your eyes once a year. We have things we have to do because it's required. We're going to give you Tecfidera. We're going to have this checked every 6 months. Watch your white blood cells. Watch your lymphocyte counts. We're going to do Aubagio. We're going to check your labs every month every week for 6 weeks, or every month for 6 months. But we're going to continue to monitor you on all these medications, and each drug matters on how it depends upon the medication. It depends what your ability is to make that happen, right? I can't come in here every time and get my blood checked. I can't come for first dose observation. Well, then, okay, it's not that therapy. So all these things we think about when we're going to give a medication, because there is some buy-in by you to follow through with the adherence. We have a lot more monitoring to do with these newer medications. There is risk. Everybody talks about the PML word, right? The PML. It exists out there. It happens on these medications. We've not seen it with the Aubagio, but we've seen it with Gilenya and Tecfidera. But we have ways of monitoring it, and we know how to monitor for it and keep an eye on it. PML is part of MS treatment today. I tell people that all the time. It's not something voodoo. It's just part of the MS landscape now and medications, and we may use these medicines. Ocrelizumab and dacrelizumab are two monoclonal antibody drugs that are coming soon. One for relapsing-remitting MS, the other for relapsing-remitting and for primary progressive. There's been, first time ever, some data to help with primary progressive MS in these two medications. And we have Lemtrada that's out there now too, a medication that we're using now to give for medications with or patients with refractory, aggressive MS that may not be responding to other medications. So the option landscape is humongous, and there's so many factors out there that we have to figure into now, and alone just not that you have MS, here's a medicine. It's who are you, what is your lifestyle, what does your MS look like, what does your MRI look like, what is your physical functioning, what are your plans in the future, and how does your daily life allow us to give you this particular therapy. So there's a ton of things. Now on the other side of that, on monitoring, what's the efficacy criteria? So the big question is, someone says, well, I've been on Avonex for 20 years, and I really, I think I want to take that new oral pill once a day. I'm like, okay, let's think about that. You're taking a medication, you've been on for 20 years, your MRI looks fantastic, you're doing fantastic, all is good. The dogma is we leave well enough alone for the most part, okay? If you're taking the drug and tolerating it, and you have a quiescent MRI, and your functional abilities are stable, we don't change. Now, of course, someone says, I'm going to quit this medicine, I'm not going to take it unless you give me a medication. Well, generally, we will make that move. But no one really argues the point. And actually, many patients, it's hard to get them to move from a therapy even when it's not working, because they really are bought into it, and they want to continue the therapy. So monitoring for efficacy is very important, and we look at several things. We look at your functional abilities. We look at what are your, I think Dr. Steingo has developed a really nice worksheet that allows patients to describe, how their daily function is affected or changing. Sometimes it's very subtle when things are changing. You don't realize it because you're with it all the time. You don't realize that, wow, 6 months ago, I was walking 2 miles a day, and now I walk the end of the street and back, and I'm tired or I can't get there. That's progressive disability. And you may not even know it unless you really start monitoring it. So we have to watch this sort of thing and watch how patients are doing. Now, NEDA, N-E-D-A, is no evidence of disease activity. It's a new acronym used in MS that we look for because we have the ability now to have that, which is the ultimate, right? No relapses, no MRI lesions are quiet, and no disability progression. That's what we expect in MS therapy now. Even 10 years ago, we'd say, well, your MRI looks a little worse, it's okay. And you've had 2 relapses instead of 4, that's okay. But now we're seeing any activity, we're very critical about whether or not the therapy runs the right therapy. And we talk about possibly discussion about making a step up, because we do have the potential ability to make changes. So that's where switch therapy comes in. And again, switch therapy is not a common phenomenon, it really isn't. If the doctor and you are making the right decision up front, that therapy should be a long-term therapy for you, i.e. in the case of somebody who is very active. Early on in MS, as I mentioned, sometimes we're very active. We see lots of relapses and we're seeing lots of activity. We put you on a medication, and 6 months later, the MRI shows 5 new enhancing lesions, and you've had 2 more relapses, we're getting off that drug. We're going on something different because it's not working, because we expect things to be quiet now. Drug side effects, I mentioned to you already, that is some of these things, but the interferons have their issues, right? Sometimes you get flu-like symptoms for those injectable medications. Sometimes you may have Injection site reactions, it may just be redness, it could be profound, it could be itching. We see it with the Plegridy, we see it with Copaxone at times. We see it with the interferons, we see the flu-like symptoms. You can see depression. I've had a few people over the years get depressed on interferons. So all these things we watch out for, and even liver function testing to some degree. The oral therapies, the Tecfidera, very good medication, but we've seen a fair amount of GI side effects. Flushing, GI upset has been an issue with Tecfidera. Gilenya pretty well managed. Aubagio also very well tolerated for most patients. Some alopecia, I've not really seen it, but it can occur, some hair thinning, but really very well tolerated medications. Tysabri, again, a very well tolerated medication and very little on the side effect profile. But we monitor for side effects, and any particular person can have any number of side effects. So patients ask me, they say, okay, so what do I expect? I say, well, here are the big things we watch out for, but anything goes. We try to listen to what you say because you may have a side effect that doesn't mean, if it's not listed in the sheet, doesn't mean it can't happen. So we listen very closely to that. We watch for the EDSS, and the EDSS is the expanded disability scale that we watch. It's a pretty good scale for monitoring for general motor function, walking ability, but it's not good in some cases for cognitive function. The 9-hole peg test and the PEG-SAT looks at cognition. So we don't use these on a regular basis. These are mostly research utilized pieces of information that we use or scales that we use, but we do use them sometimes in the clinic as well. So adherence and compliance are sort of very important, and you have to be able to, tell your physician that if you're not doing medicine on a regular basis, if you're not doing the medicine the way it's exactly prescribed, it's probably not going to work well for you, and you're better off saying I'm not doing it because you can get you on something you will use. Now, 10, 12 years ago, all we had was injectable meds. And we found out when the orals came out that more than we knew were not injecting very often. They say, I'm going to go on this oral therapy. Well, you've been on Advent, you're doing great. I haven't injected in 3 months. I'm like, ooh, or Copaxone, the same way. I inject twice a week, not 3 times or even 5 times a week, just twice a week. So we flushed out a lot of people that, not knowingly or wantingly, but they just weren't necessarily taking their medications on a regular basis because of adherence and compliance. So nowadays, with so many options, this adherence is getting better. But is once a day better than twice a day? It probably is easier to take a pill once a day than twice a day. Tecfidera is twice a day. It could be complicated there, but the once a day therapy makes things pretty easy. And that's where side effects come in. I mentioned to you already. You give someone a medication, you don't tell them up front, we don't have the discussion regarding side effects. You go home and have all these side effects, that medicine's going in the cupboard, you're not going to look at it. And we'll see that 2 months later, 3 months later, and you haven't taken your medicine, except maybe 2 dosages, and they, instead of telling you that for the first 4 weeks, or first few weeks, you may have a little GI upset, a little flushing. We can take a little, oils with this, or do something, take some aspirin, take a little prednisone, whatever it may take. For a few weeks, it'll go away. If we don't tell you that, and you just go home and take a drug and you feel terrible on it, you're not going to take it. So again, it's a matter of talking to you up front about what those side effects are going to be, understanding what they're going to be, and almost anticipate them. And when it happens, it doesn't shock you, and you stick with therapy. So quality of life, and this is a very important part of tonight. And I thought, the yoga thing is kind of cool. I've always kind of want to get into it, but my head just spins too fast. I can't get myself to go there. It's like, come on, let's get this over with, So, and it's just me. It'd probably be great if I did it, but it is good, I tell you. I have several patients who meditate, that do yoga and those things, and it really is good for the mind, and it is good for the body. The body and the mind are connected. And your immune system, you have an immune disorder. The immune system is very connected to that. And so stress, high cortisol levels, not exercising, not getting and sort of taking that time to relax can be harmful to your body. It is. And if you can get into that, it's very, very important to do. Again, I mentioned here, exercise, meditation, Pilates, yoga are all very important. And setting goals, I think that, as Leslie mentioned tonight, just pick one thing You've heard other people speak, sort of motivational speakers that maybe have MS. Just pick something that you can do, and say, okay, I'm going to climb Mount Everest, probably not going to happen, but you got to pick something you can do and shoot for that goal and make it happen, no matter how simple it is. For some people, it might be, I'm going to get from there across the room tomorrow morning in less than 20 minutes, whatever it takes, right? Just get there and do it. So socialization, that's the last little piece I mentioned. We're very much an electronic country now, or this world actually. Everybody's just in dark rooms and they text and they Facebook, and I don't even know what Facebook is, honestly. I don't Facebook. So, but Twitter and all these things, and I don't know what Facebook even is. I know what it is, but I don't know how to get on it. But I heard an interesting comment not too long ago. I was at a fundraiser, and this minister got up and he's speaking, and he said, "We are the most connected society in history right now, in the history of the world. But right now, we are the rates of suicide and loneliness and depression are the highest ever in history, even though we're the most connected. It's because we don't do this. We don't socialize. We're not seeing faces. We're not touching people. We're not looking, right? And so we're humans. We're like animals. We have to do this stuff. If we're in a room all day texting and Facebook, and you look at the crazy things people are doing. I mean, that's part of that reason, because they're festering and they're not getting out there. So socialization, I don't care what you do, at least do one thing once a week where you're getting out and you're interacting with other humans, not just electronics and things of that nature. So I went through a lot of stuff quickly, and in meds, it was part of that. The whole point really tonight is to say we have all these therapies out here. They all have their issues. They all have their positives. They all have, I don't want to say negatives, but they all have their things that we have got to be watchful for. In the right hands, they're safe. They're very effective, and you all are proof of that. I mean, everyone in this room. So my goal and my role for what I do is to keep you up, moving, and doing your things that you're doing today and years down the road. So picking the right medicines is very important, and with someone or anyone you see that knows how to use these medications. So I'm going to end it up there. I think a great part of what I'd like to do with these groups is to answer questions, and I'd like to open the room up to anyone that has any questions. Anybody have any questions? Yes. Oh, got a microphone, great.
I just wanted to know what PML stood for.
What it stood for?
PML?
Yes, it's progressive multifocal leukoencephalopathy. What does that mean? All right, I just told you. Okay, next question. Okay, so PML, progressive means progressive, multifocal, many spots in the brain, leukoencephalopathy. It is caused by a virus called JC virus. The JC virus is a virus that exists in all through the world. It's ubiquitous to our environment. About half the people in this room, on average, are JC positive, meaning you've been exposed to it. Just like chickenpox when you're a kid, you have that varicella zoster infection. It's in your spinal cord right now. It'll be there your whole life, and it's there, and it resides there. It lives there. Your immune system keeps it pushed off, keeps it in check. This immune system that runs around our body is extremely important. The reason we walk around this earth, okay? And we found out how important the immune system was in the early 80s when HIV came about, okay? So in the spinal cord resides when you get stressed, when you get sick, or if you develop a cancer or something, sometimes you get shingles, right? That shingles is just your chickenpox coming back out in that segment of the spinal cord. It could be here, down your leg, okay? So JC virus is a virus like that as well. It's in our system. About 50% of us harbor that virus, and we harbor the antibody to it, which means we've been exposed to the virus. All right. So when we test patients, we'll go and test you, and in your certain medications, we have to risk stratify you to decide if you are a good candidate for this medication. We decide, are you JC positive or negative? JC negative, okay, well, you may be good for this medicine. Maybe that's good for this medicine, or maybe if you're JC positive, well, here's options for us here. So it's a way for us to determine risk for PML, which is the manifestation of a recrudescence of the JC virus in the body. It can attack the brain. It's very inflammatory. it can be lethal. People who die from PML, but we're very good at monitoring for it, catching it early, and in many cases it can actually be thwarted and treated. But it's a place you don't want to go if you don't need to, honestly. But if it has to, we can manage with it. Did I answer your question? Okay, great, thanks.
Anybody else? Questions?
I know there's lots of questions there. Come on, here
Somebody's
we go.
gotta ask
Yeah,
something.
come on, ask about.
Wait.
Go ahead.
Whatever happens, for some times now, I was taking Copaxone and I thought I was having an allergic reaction. I explained that to the ladies in the back. But it turns out that the same thing was happening even after I've stopped taking it now for how long? 2 or 3 months, and it's still happening. So maybe it wasn't the Copaxone, and I'm not on any therapy right now. So it's
Okay, so you're having what you thought was an allergic reaction to a medication, right? Right?
yes.
Okay. And you've stopped the medicine for 2 or 3 months now, and you're still having this allergic reaction, right? All right. So the reality is, I would be hard pressed to say that the medicine's causing the problem now, because the medicine Copaxone is long gone from your system. So you need to talk to your neurologist.
You know what he did? He gave me, like he said, he gave me he gave me papers and told me to go home and read on them and pick one out. And I was like,
Well,
okay.
therein lies probably one of the most unfortunate things that happens in the MS world is they get physicians giving you, and you're intelligent. I'm not saying, but you're given information that's marketing information, okay? And some people are better at marketing than other drugs, but the drug may not be the one for you. You look at the one, that girl's running across the field, happy with her dog. I want that dog there. Yeah, right. Whatever it may be, I don't know. So, I think a lot of times what you do is, I tell you take all that stuff back in your hand, give it to the doctor, and go, listen, you're the doctor. Help me choose the medicine I'm supposed to be taking here.
Yeah.
And then, okay, but then I also might be thinking twice about asking that doctor that question, because he came to you for a reason. He gave it to you like that because he didn't know which medicine to give you.
Exactly.
Right.
That's what I'm thinking.
So, yeah, I think you need to talk to someone about that, and
Yeah.
How's that? Yeah, right. It's go ahead, Sue.
You mentioned progressive, there's a drug coming for progressive MS.
Yes.
What's out there? When is it going to be available? And all
Well,
that?
it's ocrelizumab, and that medication is finishing its final FDA approvals right now, and it's hoped by end year that we'll have this medication out for the primary progressive. Yes, ma'am. DAC?
No, go ahead, answer your
No,
question.
okay. She was, I know, sorry, no
Wait a
question.
minute.
Yes, but at the end of the year, we're looking to get FDA approval, and they're doing the finalization of that right now. So, yes, it's coming around. Good question. Thank you. Somebody else had one.
I don't know if you spoke about Lemtrada. I apologize, I was out of the room. If you did, and if you have experience with it, do you have anybody going into the second year of their infusion, and what kind of changes are you seeing overall in their status?
Okay, great question. The wrong person to ask, because I have not prescribed a Lemtrada patient yet. And they're on me to do it, but not in a good way. But I don't have any experience with Lemtrada. I know enough about the medication, but we haven't got our first year or our second year patient at this point. But thank you for asking the question, though.
So I have a question for you.
Yeah.
Concerning another infusion medication, Tysabri, and that is that when do you find that you feel that a patient might need to come off of Tysabri?
Okay, so there's a couple of different scenarios here. Tysabri, as I mentioned before, is natalizumab. It's a medication that's used to in partly affect the way these inflammatory cells traffic across the brain and cause inflammation. Very effective therapy. And we had some early on, as I mentioned to you before, we had some early on issues with the PML because it was in use in combination. So we knew very quickly we had to look into this, and Biogen looked very closely into this, and we found out that there are some risk factors associated with PML and the use of Tysabri. Those are people who have been priorly immune suppressed by medications like Cytoxan or some other immune suppressant medications in your past. 2, have you been on therapy for 2 years or longer? As far as length of time be on medication, and 3, are you JC positive? Okay, so we have the single threat, the double threat, and triple threat person. And we did a study called Stratify, and they've done several adjunct to Stratify. Stratify was stratification of patients who were at risk for developing PML. So now we can take a patient who has a 1 in 1,000 chance versus a 1 in 10,000 chance of developing PML and say they're JC positive, but they've been on drug less than 2 years, have not been exposed to medication. We have a person who is JC negative, never been on immune drug, and they're just put on Tysabri, the lowest risk. But generally, and you can take all those scenarios and mix them up, right? And that's what Stuart's alluding to. So somebody who is JC positive, okay, you get it 2 years, you start getting you might get a little itchy. And I've got patients that are past 2 years are on therapy because they are really doing well in that therapy, so we monitor them very closely, okay? But generally at 2 years, JC positive, we begin to think about making a switch to a different medication because the PML risk rises after 2 years. It's sort of, put that in perspective, it just sort of really depends on several factors, and those being your positivity. And again, the patient plays a huge role in this too, on their risk tolerance. I have patients who are 4, 5, 6 years into taking Tysabri now and doing very well. Thanks.
Yeah, see, I knew you had one. Just had to come out.
Are we getting any closer to something that would rebuild the myelin?
Yeah, the myelin project and myelin rebuilding is still in a lot of work going on there. There's work going on there in the realm of looking at cells, stem cell type phenomena. It's a lot. There's a lot going on there. Are we getting close to that? It's very, very tough. In any kind of remyelinization or rebuilding project, it's so hard to mimic what nature gave us to start with. And we can remyelinate neurons, we can, but the remyelination process is more of a dysmyelination process. It myelinates, but not the same way, and we just don't get quite that conductivity. But it's certainly a lot of work going on there, and we're working on that. But the problem with the remyelination is that in MS, we know now that it's not just a demyelinating disease, it's a axonal disease. So the axon is the wire that brings the connection. The myelin is what the covering neuron for which makes the impulse move quickly. We know early on those axons break, and that's what causes the black holes in MRI. Black holes in MRI are bad hombres. So the axons, once that's broken, remyelinate all you want. It's not going to work because the axon is broken. So then Dr. Bruce Trapp up at Cleveland Clinic did this work in the early 90s, showed that it's axons that are affected and can be affected very early on. That's why these treatments that we're doing now, these very highly anti-inflammatory treatments early in the disease state are probably saving axons early on, which is a big reason why we don't see disability down the road. Good question.
Hi, Dr. Shafer.
Hi.
I have a quick question for you about Plegridy and Ampyra. Is Plegridy considered an interferon? And does it have the same horrible side effects as the beta serum will have?
Does it have the same horrible side effects? Yeah. All right. Plegridy is interferon. It is. It's a Biogen product, and Avonex is interferon. Okay. Interferon 1A. Okay. So and Plegridy is interferon 1A also, but it's pegylated. Pegylation is a process where we sort of wrap the molecule, what's called decarboxylate molecule, around the Avonex molecule to allow it to stay in the system longer. It has a longer half-life. So by doing that, you can be injecting it sub-Q, and it now can be 2 weeks before you get your next injection. So they don't like to say it's a longer-acting Avonex, but in some way it sort of is, but it's really not. It is a bit different molecule. Does it have the same side effects? Beta-seron, interferon, Avonex, interferon, they have, as a class, they have the side effects of like the fever, malaise, chills, injection site. They may occur. If you were someone that had a lot of big problems in beta-seron, I wouldn't go near interferon with you. I wouldn't. I got lots of other choices now. I get you on something different.
And the Ampyra, that's the other
Ampyra.
one.
Yeah, so Ampyra is not a disease-modifying therapy. Okay, it is a symptomatic drug that's used for mostly to improve walking in MS patients. It's called the walking pill. The 2 studies were done with that drug, looking at walking times over 25 feet, and patients who took the medication had about 25% increase in their walking speeds. And I will, be a non-branded program here, I can tell you that I've seen patients go on Empire that have other improvements. You think if it affects walking, why wouldn't it affect your hand skills? Why wouldn't it affect balance? Why wouldn't it affect cognition? Why wouldn't it affect pain? And I've seen all these things changed and improved in Empire in some patients on this pure, case by case, this experience. But the good thing about Empire, it can be taken with any of the disease-modifying therapies. It can be used in all types of multiple sclerosis. And for those people it works for, it works. And some people, it just doesn't work. And some people I've seen, actually, it made them worse. I've had a few people that were walking, that weren't walking when they started Empire. This is just a paradoxical, reaction they can have to the medication. But for the most part, it's very positive therapy. Good question. Thanks.
I have heard many doctors speak all over the country, and I heard someone fairly recently say that the life expectancy of a person with multiple sclerosis is decreased. And I heard you say earlier that it is not necessarily decreased. So what would be your response to that?
I would say that I can provide you with the written documentation that the lifespan of an MS patient is not, at this time of day, an early diagnosis made today is the same as a person who without MS.
Thank you for that. So I have a question for you.
Okay.
So I have a question for you. With all the blood tests going on out there right now, and you hear about how they're doing this gene therapy and whatnot, and they're able to say, hey, somebody might develop MS or another disease in their lifetime. Is there anything coming about now that we would know which is the better medication to use based on blood testing?
Yeah, that's a very interesting and upcoming field. It's proteomics, and we're looking at pools of patients who have any disease state, even normal people, and we're looking at these hundreds and hundreds and hundreds of proteins. What's the protein profile of an MS patient? And we're beginning to understand a little bit about those potential risk factors in a patient who may develop or even have MS. So that being said, it's a little bit precarious because you're asking to get some kind of diagnosis on something that we can't necessarily guarantee is going to occur, and number two, you don't have a cure for. That's one side of that makes it kind of difficult. But your better question of that side of it is that how can we begin to make therapy designer for a person? We look at you and say, okay, Stuart, River, you're a Tasabri guy, and this is going to be a drug for you, because we know there's at least 7, maybe more, we call histopathological subtypes of MS. You can take a biopsy of everyone's brains at MS, and you're going to find a different look under the microscope about what kind of neurons are affected, how the white cells got in there, what types of white cells are affected in there, what is your pathology for your MS. Now, if we could do that and we could tie that to the therapy drug, we could begin to do that sort of thing. But we are working towards that to begin to say, and we've done was a trial we were involved with a couple of years ago. We actually were taking blood from MS patients. We were spinning down the blood, getting their cells that are subtype of white cells that we feel are most involved in MS, and we were developing an antibody to their own cells, and we were putting it back into the MS patient. This was in secondary progressive MS patients. That data is still being worked on. The finished trial just finished about 8-9 months ago. So we're beginning to sort of be able to get in there, get some blood from you. We can spin out your cells. What do your cells look like? Your white cells, your inflammatory cells look like, and how might those in some way connect with the therapy that we know the mechanism. We think we know the mechanism of most of the drug therapy. So to do designer therapy would be great. To say someday you're Tecfidera, you're Aubagio, you're an interferon, you're Tasabri, that would be the best. But I think the best thing would be a cure, right? Just cure this thing for sure. But if nothing else, we've gotten to a point now, as I mentioned earlier with therapy, really and truly, if you're diagnosed early and we treat you early and you get the right therapy and you got good people watching you, this is going to be something that we can manage. And I say not everybody, but put it this way: 25 years ago, 80% of people in 10 years were not ambulating without an assistive device. Okay? Now today, 80% of patients in 10 years are walking unassisted. So that's real, and that's happened in the last quarter of a century, 25 years, which isn't that much time, really.
I can vouch for that. I have
Yeah.
MS almost 20 years, guys, all right? And I remember when I used to walk into some of the seminars before I was even doing them, that I would walk in and like more than 50% of the room had people using walkers, scooters, or wheelchairs. And these days when we do programs, it's like less than 5% are in the room with mobility devices. And this is because people are sticking to what they're being prescribed to be taking and listening to their doctors. And if that doctor is not really doing it for you and you think you're getting worse, there's a lot of physicians out there. There's a lot of clinicians that are out there working with MS, and you just need to find somebody else that might do something better for you, okay?
Right, and in those cases where we're seeing patients who are, like Stu said, that are using mobility devices, many of them are patients who have had MS for 30, 35 years, who didn't have the benefit of therapy, A, and B, there really is, unfortunately, there's still that 10 to 15% of patients that have very refractory aggressive MS. I mean, it's out there. So, but the good thing is the majority of people fall in this curve where we can do a lot of help with the medications today, and it's just getting better. We're getting closer and closer. Yes. Oh, we have a question. Wait. Wait.
I got a big mouth.
You're recording.
I gotcha. I was diagnosed at 22, so I've had this over half my life. I've been dealing with this. I have always told my children that it's not hereditary, but now I'm hearing conflicting things that it could be, it may be. Is it? Are there studies out there?
That's always a great question. Here's how it works. There are hereditary diseases, and there are diseases which have genetic predisposition. A hereditary disease is like Mendelian genetics, and that's basically the basis of all genetics, how we look at diseases. People with Huntington's disease, that has a dominant sort of penetration, the way it works in the gene pool. 50% of a sibling or someone who is a child of a parent who has Huntington's has a 50% risk of getting Huntington's disease. Okay, guarantee you, if you got 4 people in your family, 2 or at least a quarter of them are going to have Huntington's. MS is not necessarily a heritable disease, but you definitely see in first degree relatives, you carry a higher genetic predisposition to develop an MS. So they're not destined to get MS. They're not, okay? Now, could that person be involved in the same environment, get exposed to the same kind of antigens, and all the things line up the same way? They may be at risk. But because you have MS does not mean that your children are going to look forward to having MS. I mean, if it was true, we would not tell women of young bearing age, get off therapy, and let's have babies, let's have families. We want you to get, young women to take a break, get pregnant. Usually pregnancy is great for MS. They love it. They just can't believe how good they feel. And then they go back on their therapy. Right. So no, you're good to go there.
I've been telling them the whole. I'm like, no, you're fine, but now I'm hearing things like.
No, you're fine. You always will be fine. Good question. Very good question, though.
Any questions? If not, I have a question for you all. Anybody here have urologic problems, bladder issues? Do you not have a question about your bladder issues that you want to ask? You're here right now. You can get an answer. You're going to ask where the bathroom is. Out the door and to your right. Would you like to ask a question?
I had the bladder issue before when I was on Rebif. I actually stopped taking it because I didn't like doing the injections, and it came about. But if I were to want to have another baby, because I'm only 29 now, I stopped my medicine, and then what would I have to do?
If you wanted to have
have
children?
another child.
Another child?
Yeah.
So, well, I think you have to talk to your person who's treating your MS and say, okay, I want to have another baby. And we would get you off therapy because, you got to be, we want you trying to get pregnant on therapy. So we get you off medicine, and I usually give you a window.
Okay.
So you got 6 months. You better get hopping.
Well,
and we see how that goes. It depends on listen, if your MRI is stable and you've been doing great, rock solid good for a year, then that's low risk. If somebody's got last MRI did 6 months ago, had a lot of lesions, and you're having relapses like crazy, I say we're taking a little risk here because you might do good during pregnancy, but at the end of pregnancy, you may have a relapse. It could be pretty profound. You have to decide on that risk when you decide. Again, it depends on the person, but it's not an issue.
Okay. Well, my other thing is, with my first pregnancy, I wasn't taking any medicine, and my child was supposed to be born around Christmas, and she came a month early, and that was all related towards my MS. No, is that possible? It could happen again, or should I expect that, or?
Well, I don't think pregnancy in term of pregnancy is necessarily affected per se by MS. I'm not aware of that, and we can't predict late, early. It's a lot of factors that come involved. It's not just the MS, but a lot of factors play a role in that. But it's a good question.
So my next question for you all, who has spasticity problems? Do you have any questions about the spasms that you get in your body day or night? You don't have any questions about that. Does anybody have cognitive problems, memory issues? Aside from getting older. Do you have CRS? Okay, I'll explain that afterwards.
Yeah, right. It's on camera.
Do you have a question?
No, I'm the president of that.
Society, CRS Society.
CRS Society, got it. Okay, we'll definitely have something to talk about after. How about, okay, there's a question in the back. All right. So I'm trying to get you guys to ask some questions, and that's why I'm bringing up all these pointers.
Nope. And we get done back there, we have one up here too.
Okay. Spasticity. It was recently suggested to me that should it ever become legal in Florida, I should consider medical marijuana for spasticity. What are your thoughts?
Okay, here's the skinny on medical marijuana. I have no political lining up with marijuana and that sort of thing, but there is no literature out there that states that marijuana has any neurological benefit and any neurological diseases that is done under the right rigidity of scientific trials. We do know that marijuana long-term use does affect the brain in a negative way in creating early cognitive dysfunction and dementia. We know that. So in my book, from a scientist standpoint, I would not suggest the use of marijuana for those patients that have spasticity. And I've got a handful or more of patients that say they do great with it. It helps their pain, it helps their spasticity and that nature. But on a scientific basis, it's difficult, if not, well, not say difficult, it's just that there's no scientific data that's been large-scale studies out there that show that we have any real good data that says that that's going to help us.
Who's the question up here?
Yeah, I think you got a question here. Oh, you got it? Okay.
Okay.
It was, you answered it. It was the spasticity that I have.
Okay.
And I wanted to
know
know
and
if
medication-wise with spasticity, we've had, spasticity is a result essentially of a disconnection between the brain and the spinal cord. Okay, our spinal cords are very, very hyperactive, right? If we, you ever step on a spider and it just crunches up? Well, it's just a big spinal cord. For us, we think that the brain is what stimulates our body. It doesn't. Our brain is a great inhibitor. Our spinal cord is very, very hyperactive. And the brain has a lot of negative influence nerve cells that go down to your spinal cord, and they negatively impact your spinal cord. So we're nice and smooth, and we're slow, and this sort of thing. If you have MS, you're affecting those upper motor neurons, which means nerves above the spinal cord are affected. And you disconnect the spinal cord. The spinal cord is spastic. Spinal cord, boom. So when you step on a hot coal, what happens? Your foot comes off that coal before your brain realizes it, right? You grab that stove, your hand comes off that stove before you even realize it. You know why? That's your spinal cord reacting, and your midbrain, not your brain up here. Okay? It's a protective mechanism. It's very important. So as we get lesions, we get more spasticity. And spasticity is a consequence of upper motor neuron dysfunction. Medicines are tizanidine, and we use Valium, we use baclofen, pumps are used, and all benzodiazepines can be used for spasticity and to help minimize some of those symptoms. Okay.
Why do they say eat bananas for spasticity?
Potassium.
And what does it do?
Potassium is it helps conduct nerves better. Okay, because that's, if you think about Empira, right, what it does supposedly is it's a potassium channel blocker. So as nerve cells run down the neuron, your potassium ions are going out into the air because the myelin's not around there. So we block those little holes with the Empira so the potassium stays in the nerve cell and conducts down the nerve cell. So we need potassium to create what's called saltatory conduction in neurons. Very, very important.
And what is a better diet for people to use while they're, what's the best way they should be eating?
Well,
What should they not be eating?
Well, yeah, here's what you do. You ever hear the perimeter of the grocery store? Right? The perimeter of the grocery store is where you should be eating, because that's where all the fresh foods are, and fresh fruits and vegetables and meats are, okay? You start getting to the center of the store, it's all that frozen stuff, all that sugar stuff, all that high-fat stuff, and even fats aren't bad for you, they're the wrong kind of fats. But, you know, clean foods are very important. I don't believe there's a, quote, diet out there per se. I think dieting is really, you know, it's called eating sensibly, portion control, eating the right kinds of foods. Fresh fruits, vegetables, you know, good clean meats, low-fat meats, good oils, avocados, peanuts, nuts, those sort of things are very, very important. Anything antioxidants, very important as well, too.
Okay, any questions? Oh, well, you have a question.
Good night, y'all. Thank you for coming. Fantastic.
Yeah, back to the specialized issues like urological problems that are related to MS, problems that are related to MS. Should you see a urologist, or should you see your neurologist when you have those types of problems?
That's an excellent question. So your urological issues, you know, 90% of patients at some point in time with MS are going to have neurogenic bladder. And that could be anything. It could be a lazy bladder. It might be a spastic bladder. It might be an urgent bladder. It could be a hesitant bladder. There's so many variations because the bladder is very complicated. You have the upper sphincter in your bladder. You have a lower sphincter, and you have urethral sphincter. You have all these levels where your bladder can be dysfunctional. So you can get a lazy bladder gets big and lazy because the upper bladder sphincter is not working. Lower bladder is not. There's so many levels. So for that reason, a urologist is very important. I have a urologist in Vero Beach here who has a sister with MS, and he's incredibly bought in and works with my MS patients. He's very, very good. So urodynamics is very important. We go in there and they fill the bladder up, and they actually can decide where in the bladder function, where bladder sphincter, and how is your bladder functioning, what's the problem there. And by doing that, we know what kind of medicine. Do we use alpha blockers? Do we use Flomax? There's so many kinds of urological medicines to use. We have to decide, you know, which therapy is the best for you. Now, that being said, bladder, you know, we try medications. We try doing bladder, Kegel exercises, all kinds of things to try and strengthen the bladder. Some people end up having to use self-cath over years. Self-cathing is very traumatic to the urethra. It's hard for caregivers. It's hard for the patient. They're stuck with all kinds of things in that nature. We go to what's called suprapubic catheter, which is a catheter that goes above the pubic bone into the bladder and the abdominal wall here. You're not invading the urethra. You can, it allows you to maintain normalcy of anatomy. It's an easy way to access your bladder. It has less infections, and in the long term, its quality of life issues are very good, especially for people who are not ambulatory, who have a lot of issues with catheter and self-catheterization issues. But it's a good question. Thank you.
Any other questions? So, go ahead.
Wait. Sorry. The stem cell, you said with progressive, that's when you do it. It's not for people with R&R?
Right. It wasn't actually stem cell. We took the person's own blood and made some cells and antibodies against their own white cells and gave them back to them for that study, the secondary progressive study. At the moment, stem cells are not FDA approved, or are there really any good data that say that they're going to help in the treatment of MS at this time? But we're working on those sort of things. But good question.
Anybody else?
Early.
Wow, look at that. Wow. See, now they're coming up.
We can't stop them.
We're down to the wire here.
What are your thoughts on B12 shots? I read a lot about people taking B12.
Yeah, well, B12 is a very important cofactor for neurologic function, especially nerve function. And in some cases, people don't absorb B12 well because they don't have intrinsic factor in their gut. And the older we get, the more likely it is that we don't have intrinsic factor. When you take B12 by food, it binds to the intrinsic factor, it goes into your gut, and it's absorbed to your body. If you don't have intrinsic factor in your gut, which is your stomach and your upper intestine, you're not going to absorb it. So that's why people who take pills all day long, take it all you want. It's not, you see, it's going to have really pretty urine and expensive urine, but it's not going to help you a bit. So If you have low B12, you only can be tested by looking at what's called the methylmalonic acid. Make sure your doctor checks the methylmalonic acid. If the B12 is low, methylmalonic acid is normal, you don't need B12. If your MMA is high, you need B12, even if your B12 looks normal on the test. So that's very important. And you get it injected. When you get it injected, it bypasses your gut, it goes right to your system, helps out nerve function, helps with energy and general neuronal function. But yes, it can be used in the right context. Good question.
Any other questions? Okay, so firstly, I want to thank Dr. Shafer, and I hope you all do too.
Thanks, Stuart. I really
You're welcome.
Always good seeing you. Thank
You're
you
welcome.
very much.
You're
Thank
welcome.
You. Thank you.
And secondly, I didn't get to thank them at the beginning of the program, but I hope you all appreciate that Teva Neuroscience gave us the funding to do today's program. And we respect the pharmaceutical industry who gives us the funding to do all of our programs, because they actually do want to see you get educated. They want you to work with us and be empowered with MS information, education, and the resources. And so I will thank Teva, and I hope you all do too. Thank you.
Thank you.
So other than that, we get around to this area like once a year, and if you'd like to see us around more often, or if you want to know anything about MS that you're not finding from your neurologist or whoever it might be, you can give us a call. We also have a social worker. If you ever need to know about resources, where you can get things, even to find out where you can get connected with somebody that you need financial assistance for anything, our social worker will work with you on that. We have an 800 number. You just go to our website, msviewsandnews.org, and you can look up and see the phone number to connect with our social worker. Excuse me. And then you could also go to our website, and you could also see all the other programs that we have happening around the country. We are doing programs now in 13 states. Okay, so we have been doing this for a while. We usually do a lot in Florida, but this year we cut back on Florida because everybody outside Florida is asking us to get to their areas. So we're going to be doing a lot in many other states, and hopefully by the end of this year we'll be doing programs in 17 states. So again, it's just people need information, and we believe we can give this to them. Thank you again for coming tonight.
All right, thank you. And let's thank Stuart from MS Views and News. This guy puts a lot out there for us and MS patients. Thank you, Stuart, very much for your help. Thank you very much.